So we'll begin the lymphatic system today. And here, if you look at, so just want you to look at this first picture, which is really nice. So here is the circulatory system which you did. So, you know, the heart, and you can see the arteries, and then they break up into capillaries, and then from the venous end of the capillaries, the veins go back and they take the blood back to the heart, right? Now, at this capillary end, if you remember, we saw how hydrostatic pressure throws fluid out and osmotic pressure drew fluid in. But some of the fluid still remains outside in the interstitial space which bathes the cells. That fluid is made up of plasma which has seeped out with lots of proteins in it, okay? That fluid is really lymph. And when it goes into capillaries, so these are the lymph capillaries, they start as blind-ended vessels. And you can see then they become, you know, like a capillary. So they are small, then they get larger, and they form large lymph vessels, and then they go back. And then that's how they return the blood, the extra tissue fluid back into circulation. And at different points, they are interrupted by lymph nodes. And the lymph nodes are such, they are like toll stations in between, so that any cell debris, pathogens, viruses, anything which needs to be taken care of, these lymph nodes can do that, okay? So I want you to kind of look at this picture, and then after a while we'll have a few questions on this. So let's look at the organs included in the lymphatic system. So you have two central organs. This is where actually in fetal life the different types of lymphocytes, they get mature and they are kind of primed. And the two central organs are the thymus, where T lymphocytes go to get mature. And then we have bone marrow, which we'll see when we do the immune system, where B lymphocytes form and they get primed and become mature. These are the other lymphatic organs. So we have tonsils. Normally you tend to think of tonsils when someone says, you know, you have inflammation of the tonsil, there's only one that you think of, and the one that you're thinking of is the palatine tonsil, which is, you know, you kind of loosely point to this area of your throat, and you think that when it's swollen, that's where it is. And what you're feeling when you actually press along your neck, you're not really feeling the tonsil. What you're feeling is a lymph node that the tonsil drains into. So if that palatine tonsil is inflamed, that lymph node will be swollen, and that's what the doctor is really feeling. So tonsils, also known as tonsillar tissue. So this is also often called tonsillar tissue. This is seen in the throat area, or what is anatomically correct is the pharynx. And we'll see that in different areas of the pharynx is where these tonsils lie. There are 4 named tonsils. You have the other little tonsillar tissue all around, but they are not named. The 4 named ones are lingual, which means on the tongue. Palatine, so this is the one which is the most common, which when it gets really big you find it difficult to swallow. There's one called tubal tonsil, which is present in relation to the eustachian tube. So this is in relation to the eustachian, or what is also known as the auditory tube. And pharyngeal tonsil, which we'll see, which is on the posterior pharyngeal wall. This is the one which when swollen we call adenoids. Okay, when this is swollen, we call it adenoids. Then we have lymph nodes, so small bean-shaped structures. So here, what you can see, the tonsillar tissue is not really all that well seen, but you can see these lymph nodes up here. You can see all of these lymph nodes. Lymph nodes tend to collect in certain areas of the body. Some of the common areas where lymph nodes are collected are in the neck, where they are known as cervical lymph nodes. Then you see a big group of lymph nodes present in the axilla, called the axillary group of lymph nodes. And then you see lymph nodes in the groin area, known as the inguinal group of lymph nodes. You see a lot of lymph nodes which are present in the abdomen. So here within the abdominal organs also they are present there. They're called mesenteric lymph nodes, aortic lymph nodes, different names. But on the outer surface of the body, the ones you can actually feel are the cervical group of lymph nodes. And notice how everything kind of drains to a regional area. So anything to do with the head and neck, most of it will drain into the cervical group of lymph nodes. So if somebody has even lice in their hair and they scratch and infection occurs, it will be the cervical group of lymph nodes which will enlarge. If somebody has anything in the toe, foot, here or leg, you can see all of this drains, into maybe first popliteal, then they go up into the inguinal. So the lymph is going this way. So the inguinal group of lymph nodes will be enlarged. If someone has any problem in the upper limb or something in the thorax, it's the axillary group of lymph nodes which will, get enlarged. And then we have what are called lymphatic nodules. Nodules are also known as follicles. So these are round structures, lymphatic tissue, which is usually present. So it's lymphatic tissue made up of lymphocytes and macrophages. Main cells in the lymphatic system are lymphocytes and macros. So, these are the nuclei which you see. So it's in a round shape, but these nodules, or what we call follicles, are present as part of another organ. So they're in the wall of another organ. When they are in the wall of the small intestine, we call it the Peyer's patches, sometimes spelled with an E, an A and E, and sometimes just with an E. So here the Peyer's patches, these are present in the small intestine. They're given a special name. But otherwise, you might see lymphatic follicles present with relation to anything where there is exposure. For example, the respiratory tract, the gastrointestinal, other parts of the gastrointestinal tract other than small intestine, the urinary tract. So all of these, they're exposed at some point or the other to, outside, like respiratory tract, you breathe in air, you can take in stuff of gastrointestinal, you take all kinds of food, so pathogens can go in. Urinary tract infection could spread from below, so all of these. So wherever there is the possibility of an infection, the body wants to protect it, so you have these aggregations or collections. In fact, most areas which have a blood supply invariably have a lymphatic drainage, because lymph, what does it do? It just collects that tissue fluid, right, which has seeped out. Some areas which don't have lymph vessels are bone marrow, so that's one area, and even the brain. Even though the brain is well supplied with blood, it doesn't have any lymphatic vessels. Another organ is the spleen, very, very large organ, the largest lymphatic organ. And then, of course, the bone marrow. So let's answer a few questions here. Don't have So what is the direction of lymph flow? So you looked at the first picture. So see what is the direction of lymph flow. It is towards the heart, not away from the heart, or not both towards and away, because let's go back and let's look at that picture. Remember, lymph vessels take the lymph back, the fluid back into circulation, which means they are like veins. They are going back into the blood circulation. So notice how here, look at the direction it's going. It goes into a vein from above. Also, it's coming down and into vein. So it's towards the heart, okay? So it's towards the heart. And another thing you can see from this picture is the lymphatic vessels finally drain into veins. So that's another important thing for you to remember. So it finally drains into the veins, and that's how the blood goes back. All of the remaining fluid, which is in the interstitial space, that fluid goes back into the circulation. Okay, I just gave you this. So where does lymph finally drain? Come on. Into veins, yes, into veins. It goes into veins. You noticed how it was opening into the veins, not into the extracellular space. It removes the fluid from the extracellular space, taking it back into the veins. Okay, so that's where lymph finally drains. Now let's look at the first of the lymphatic organs. So the thymus. It's a large lymphatic organ, especially in childhood and adolescence. You know, once you start hitting puberty, then this lymphatic organ begins to involute. Involute means it regresses. And in fact, if you look at a cadaver, you often find that this thymus is very difficult to see. It's just a thin strand. You can barely see it in the neck or in the thorax. It is said to be a bilobed organ, so there are like two lobes, this one big lobe and another one. They may not always be seen that well. Very vascular. This is the area where it's one of the central lymphatic organs. So during fetal life, which we'll see in the immune system, when these lymphocytes are being formed, the ones which are destined to form T lymphocytes, they go into the thymus to mature. So it makes the T lymphocytes immunocompetent. That means it trains them to become competent to take part in the immune response. It produces many hormones, of which thymosin is one of the really important ones. So you can see here there's a little review of all the things that have to do with the thymus. And if it is often involved in an autoimmune disease which is known as myasthenia gravis. So the thymus is to blame in this situation. Let's look at the histology of the thymus. So imagine that if you thought of these as the two lobes, so this is say one lobe and this is another lobe. What happens is the thymus has a capsule on the outside. Many organs have connective tissue which is present on the outside, which is called the capsule. And this capsule sends in little sort of septae inside. Septae are like little walls inside. So these are septae. This is a septum. Septum is singular. Septa or septae are plural. So when it sends these septae inside, it breaks each lobe itself into tinier bits which are known as lobules. And the periphery of the thymus is known as the cortex. It's much darker staining. So the cortex is darker staining. And here this is the cortex. This part here you can see the cortex is darker staining. The central area which is lighter staining is called the medulla. And what you can see in this picture, if you notice, the cortex is kind of confined to a lobule up here. Can you see that? The cortex is confined to a lobule. The medulla kind of spreads around, but it's still present only in the center. And in the medulla, right here, so this here is the medulla. So here, this is the cortex. This area here is the cortex. This part here is the medulla. And very characteristic of the medulla is the presence of these round pink structures, which you can see here, which are known as Hassel's corpuscles. So this is a very typical feature of the thymus. And if you look at Hassel's corpuscle, it really has an onion peel-like appearance. The cells actually are like this. They kind of, if you look at it in very high power, you'll be able to see this. The cells kind of lined like this. So can you see it kind of gives an onion peel-like appearance? The function of the Hassel's corpuscle is not known. They think it's probably the cells are dying in this area. And the reason why the cortex is much darker than the medulla is because the lymphocytes, if you remember when we were doing blood cells and we looked at a lymphocyte, and the nucleus of the lymphocyte is really dark, purplish, and the cytoplasm is very little on, like this. So most of the time you see just the nucleus. In the cortex, the nuclei are all very closely aggregated like this. So can you see they're very, very close to each other, which gives it a dark appearance. In the medulla, they're a little bit more spread out. So that's why you have this lighter appearance in the medulla, not as concentrated. One thing which is very also seen in the thymus, you have Hassel's corpuscles. Another thing is that you do not see any germinal centers. And in a later slide, when we talk of another organ, we'll talk about what germinal centers are. But in the medulla, you do not see, or in the thymus, you do not see any germinal centers. So here again, just a review. You have cortex and medulla, septate dividing it into lobules. Hassel's corpuscle seen in the medulla, but no germinal centers seen. The cortex is much darker than the central medulla. Okay, so characteristic feature are the Hassel's corpuscles and this cortex and medulla. Let's look at these tonsils. They are present in this area which is called the pharynx. What you loosely call your throat, that's the pharynx. And if you see, let's sort of demarcate the parts of the pharynx. So this is the nose, nasal cavity. This is the oral cavity, and this part here is the larynx. So this is the nasal cavity here. This is the oral cavity. And this here is the larynx. So if we draw a line from where the posterior part of your nose ends, at this point where the nose ends, we also draw a line through folds. When you open your mouth and you look at the back of your tongue, you can see two folds which go from the soft palate down to the tongue, right? So at the beginning of the first of those folds, and you take the line across from just crossing the larynx this way, all this area here is called the pharynx. This part which is behind the nose is known as nasopharynx. This part which is behind the oral cavity is called oropharynx. And this part which is behind the larynx is called laryngopharynx. So it automatically tells you what it is behind. And notice here in the nasopharynx, you can see these are the two tonsillar tissues that I'm trying to show you. This one, which is over the auditory tube, this is known as the tubal tonsil. So this one here, this green bit, it's over the auditory tube. It's called tubal. That's why it's called tubal tonsil. So it's above the auditory or eustachian tube, or also called pharyngotympanic tube. Auditory tube or eustachian tube, or also called pharyngotympanic tube. This is a really good name, pharyngotympanic, because it connects this nasopharynx to the middle ear cavity. That's why it's called pharyngotympanic. Nasopharynx to middle ear cavity. Pharynx to tympanum is the middle ear. So this lies over the tube, eustachian tube. And here on the posterior wall of the nasopharynx is this pharyngeal tonsil, which when swollen, it's called adenoids. And you can understand if it swells really too much, if it swells a lot, can you see like this? It will become really swollen and big. What will happen when this child is breathing? They find it difficult to breathe, because can you see this passage has become really narrow? So very often these children who have swollen pharyngeal tonsils, they have difficulty breathing. They sleep with their mouth open or breathe with their mouth open because then, it cannot go through the nose. Growth becomes a little stunted because, again, a lot of problems they have, and you have to remove those tonsils. Then when you look at the oropharynx, you have a tonsil which is present in between those two folds which come down from the pharynx. That is the palatine tonsil, the one that you actually look at when you open your mouth and you stare inside and you see those two swellings in your pharynx. That's the one you're really looking at, the palatine tonsil here. And then there is a single one which is present just under the tongue. If you look at the back of your tongue, it kind of looks a little like it's not smooth. It kind of looks like a little bumpy. And that's because of tonsillar tissue which is present underneath, and that's the lingual tonsil, okay? So you have one pharyngeal tonsil here, one lingual, but these other tubal and palatine are paired. So together they form a ring around your pharynx, which you can see here, which is known as the Waldeyer's ring. So if you start from the top, and this is the pharyngeal tonsil, so here pharyngeal tonsil, you go to the side, this is tubal tonsil. Then you come down to the palatine tonsil, and then you come down to the lingual tonsil. So this is one side, and then we'll go back again to palatine, tubal, and then back to the center. So can you see this tonsillar ring around in your pharynx, which is known as the Waldeyer's ring? Okay? So let's stop here. So we saw the tonsils in the Waldeyer's ring, and just let me make sure. So now let's answer this question. Where are the tonsils present? Yes, in the pharynx. Remember the nasopharynx and the oropharynx. The tubal tonsil and the pharyngeal tonsil in the nasopharynx, the palatine and lingual in the oropharynx. So here let's look at typical tonsillar tissue, and I'm using palatine tonsil as an example. So one of the first things you see in the tonsil is that it is covered by epithelium because it's present in the pharynx. So it has a surface which faces the pharynx. So there is an epithelial covering which you see here. So in the case of tonsils which are present in the nasopharynx, the epithelium will be based on whatever the nasopharyngeal epithelium is, which is very similar to respiratory epithelium. So in the nasopharynx, the epithelium would be pseudostratified, ciliated columnar epithelium. And here, the palatine tonsil, which is present in the oropharynx, here the epithelium is stratified, squamous, non-keratinized. The lingual tonsil will also have the same kind of epithelium as palatine because they're both present in the oropharynx. What is also typical of the tonsils is that the epithelium dips into little sort of valleys or grooves which are known as crypts. So here you see crypts present, and so the epithelium lines the crypts. There is no cortex or medulla, but just under the epithelium, all the lymphocytes and the macrophages, they kind of get together, they aggregate, and they form these round structures which are known as lymph nodules, or also known as lymph follicles. They're also known as lymph follicles. And often when you look at tonsil, this is not part of the tonsillar tissue, but often because you can see these mucous glands and skeletal muscle, you might think it's part of the tonsillar tissue. It's not. It's just because tonsils lie in the pharynx where you have pharyngeal skeletal muscle and you have a lot of mucous glands. That's why whenever you take a slide of the tonsil, you often see these two structures along with it. But that's not part of the tonsil, okay? So what is part is epithelium, crypts, the presence of these lymph follicles, And since tonsils tend to get infected very often, what you'll have in the lymph follicle is a central area which might be lighter staining. So you can see this central area here is lighter staining. That is known as the germinal center. And the reason the germinal center is lighter staining is because it is made up, if you remember, lymphocytes were cells which had very little cytoplasm. They mainly had a nucleus, and the nucleus was kind of purplish or dark blue, purplish in color. But and this is the cytoplasm. In the germinal center, you have cells which are known as lymphoblasts, and these have a nucleus, but they also have a lot more cytoplasm. So the cytoplasm is pale blue in color. So because of the presence of more cytoplasm, that area looks lighter stained compared to the periphery. Okay? So germinal center is usually seen in the center of a follicle. It signifies the presence of infection, because if there's an infection, then the lymphoblasts will begin to form more lymphocytes to combat the infection. So in order for that to happen, they'll begin to multiply. So whenever you see a germinal center, that means infection is present. So here are some of the salient features of tonsils. They are present in the pharynx. The epithelium is, depending where it is, pseudostratified or stratified squamous. They have crypts, they have follicles, and the follicles may have germinal centers. Let's look at this question. Why is the epithelium different in these two areas, in the lingual tonsil and different from that of the pharyngeal and tubal tonsil? Very good, yes, because of where they are present. So if they are in the nasopharynx, they automatically get the epithelium of the nasopharynx. In the oropharynx, they get the epithelium of the oropharynx. Excellent. Okay, now you did thymus initially, and now you have done tonsil. So if you were to differentiate them histologically, which of these answers would hold true? All the statements hold true. See, the thymus has only the thymus between these two. We are only talking about these two. Only the thymus has a cortex and medulla. The tonsil has epithelium and crypt. So automatically these two statements are correct. And remember, the thymus does not have germinal centers. Only the tonsil has germinal centers. Okay, so all the statements are true. Now, if the palatine tonsil was enlarged, what do you think would be the effect? So think here, where is it present? What would be the problem? The person would have difficulty swallowing. Yes, that's right. Remember, it is present in the oropharynx. And you swallow, the oropharynx is, and let's go back to look at the slides. The oropharynx is just behind the oral cavity, and obviously when you swallow over here, the food will go down. Now if this is swollen, it's going to cause a difficulty in swallowing. If the pharyngeal tonsil was enlarged, which is when adenoids, then you'd have difficulty breathing. We expect that everybody is a nose breather, not a mouth breather. And if the tubal tonsil was enlarged, what would it do? It's lying on top of the eustachian tube, so it would compress the eustachian tube, and then these people might have ear infections, because the eustachian tube connects the middle ear cavity with the nasopharynx. So ear infections become common if that area is blocked, okay? Even if the lingual tonsil was enlarged, usually it isn't, but if it was really big, this also would have they would have problems with swallowing, okay? Now let's look at lymph nodes. So first we look at the gross picture of lymph nodes. As I told you, lymph nodes are present all over the body. I mentioned in certain areas they are aggregated. You see huge collections. For example, in the inguinal area, here in the groin, so they are known as inguinal lymph nodes. Then you see them in the axilla, the axillary lymph nodes. You see them in the neck area, they're called the cervical lymph nodes. They drain all the areas. For example, the scalp and the neck and face drain to cervical. Most of the upper limb and the thorax drains into axillary. The lower limb drains into the inguinal. And then inside the abdominal cavity, you have a bunch of lymph nodes which are present with the various organs. So, depending on where they are present, we colic lymph nodes with the colon or mesenteric lymph nodes with the small intestine. And then these lymph nodes, you can see, are connected to each other by lymph vessels. And these lymph vessels, you can notice all of them, they drain into big channels. So there are two main big channels. The first one is what is called the thoracic duct. It begins from a small little pocket or dilated sac which is present in the abdomen. So this thoracic duct begins from there. It travels through the abdomen into the thorax. It goes all the way up into, because remember, lymph is flowing up, right, towards the heart, because it has to drain into veins. And it goes up, and then it opens on the left side. It opens into the junction between the subclavian internal jugular. So it opens into a vein. Remember, lymph all finally went into a vein. So this thoracic duct, it drains, as you can see, most of the body. So look at what all it drains. So, it drains below the diaphragm, it drains everything, right and left sides of the body. And then in the thoracic region, above the diaphragm, it drains the left half of the body. So the left thorax, the left upper limb, and the left side of head and neck. Can you see that? That's what the thoracic duct is draining. So how about this right side then? The right side has a separate lymphatic duct, which is known as the right lymphatic duct. So this drains the right side of the head, the right upper limb, and the right side of the thorax. And it also opens into a vein symmetrically. So it opens between the internal jugular and subclavian at the junction there. It opens there, the right lymphatic duct, okay? So the thoracic duct area of drainage, you can see, is really, really vast. That of the right lymphatic duct is much slower. That's how finally all of the lymph is brought back into the circulation, because it pours it into the veins. Now let's look, if you were to take one lymph node and you took a section of the lymph node, you will notice that it has a very thick capsule on the outside, which is just made of connective tissue. And there are many vessels which open, lymph vessels which open into it. So you can see these lymph vessels which are going towards the lymph node. These lymph vessels are known as afferent lymph vessels. And then coming out from the lymph node are fewer efferent lymph vessels. How this helps is, because lymph is flowing, a lot of lymph flows into this lymph node. It has to travel through here, through this entire lymphatic tissue. And then because it only has a few exits, what happens, lymph kind of stays in the lymph node for a while. When it stays there, it makes the lymphocytes come in contact with any pathogens or cell debris or anything they need to come in contact with and take care of. So it keeps the lymph longer in the lymph node, making these cells come in contact with them, and so it can do its job. That's why you have more afferent and fewer efferent lymph nodes. Also, if you notice the shape of the lymph node, look, it's kind of bean-shaped or kidney-shaped. So there is this convex area, and this area here is known as the hilum. This concave, like little indented portion is known as the hilum, where you have these efferent lymph vessels, and you also actually have blood vessels. So you have veins which come out, and you'll have arteries which will supply it. So you'll have arteries as well, arteries going in. I also want you to pay attention. Lymph is very similar to veins. So it has valves. So look at these lymphatic vessels. They have valves so that lymph only flows towards the heart. especially in the lower lymph nodes, the lymph nodes which have to go against, lymph vessels which have to go against gravity. Skeletal muscle activity, like veins, is also important for squeezing lymph vessels and pushing the blood up. Inspiration, when you inspire, the thoracic pressure decreases and it sucks the blood up, same way it helps to suck lymph up. So all the things that help veins take the blood back to the heart help lymph vessels also. Now here, if you look at a cross section of a lymph node, you will notice under the capsule there's a little sort of space present which is called the subcapsular sinus. It's nothing else but just the space where the lymph kind of flows in from here. It flows in and it just percolates slowly. Then the lymph node, like the thymus, is divided into a cortex and a medulla. So the cortex is the outer area. The medulla is the central area. So this is cortex, that is medulla. In the cortex, this capsule sends in little septae. So you can see these septae going in and dividing it into smaller areas. And here you see in the capsule, the lymph, and these septae are also called trabeculae, or also known as septae. And in the cortex, the lymphoid tissue, the lymphocytes and macrophages, they are aggregated as round structures which are known as lymph follicles, or also known as lymph nodules. So here you can see these are all the lymph follicles. So you can see these lymph follicles present there. When you come to the medulla, the lymphocytes and macrophages, instead of being aggregated as round structures, what they do is they kind of come down and get together as more rod-like or linear structures like this. So they look very cord-like or rod-like. So they are known as medullary cords. So can you see these? These are the medullary cords. They're not round. And in between the medullary cords, you have a lot of spaces present. So imagine if you have medullary cords like this, you have these spaces present, which are just dilated lymph channels. These are known as medullary sinuses. So this helps because lymph first comes in, passes through this subcapsular sinus, then passes through here, then it goes into the medulla in the sinuses. So all, it collects in all these areas, so that making the lymphocytes come in contact with anything that needs to be taken care of before the lymph exits. Okay? So this is the structure of a lymph node in cross section. Yes.
Would you say that when you're talking about things that assist in like venous return, also increase lymph return, would you say that somebody who has poor venous return would likely have poor lymph return?
Someone who has poor venous return, whether that person will have poor lymph return, not necessarily so, because they could have poor venous return if they have varicose veins.
Okay.
But they don't necessarily have to have a problem. Everything else may be working, but the lymph would be normal,
Okay,
So yeah. So not necessarily, no. So let's look here, just a quick view on this. So this has no audio, but it's just showing you how blood percolates into the interstitial spaces. These are proteins picked up by lymphocytes, taken back from the interstitial spaces. So they pass through lymph vessels. And here they meet a lymph node. So this is an afferent lymph vessel. Inside the lymph node, see more afferent, fewer efferents. And you can see here, they pass in and then they'll pass out. You can also notice the blood vessels there. After going through a lymph node through efferent, then they go into the thoracic duct and finally into a vein and back into the heart. And then there is the right lymphatic duct on the right side. Okay? So here again, cortex and medulla, follicles or nodule, cortex, medullary cords and sinuses in the medulla. So typical features of a lymph node. Okay, so I already kind of told you this question. Lymphatic vessels are very similar to veins. So what is factors responsible for movement of lymph? So I mentioned, so it's really all of this, including pulsations of arteries, because very often they lie close to lymph nodes, to lymphatic vessels and veins, and that helps too. Okay. Now, if suppose your big toe was infected, which areas would be affected? Or which areas would the lymph nodes be swollen? Ooh, lymph nodes all over the body. No, sorry, good. Yes, the regional lymph nodes. Yes, very good. Yeah, because lymph nodes just drain areas they are close to. So just the regional. If you had cervical lymph node enlargement, you would expect some problem in the head and neck area, you know, scalp infection, something in the tonsils, something like that. Yes, regional lymph nodes. Okay, what is the direction of lymph flow in the thoracic duct? Very good. From abdomen to thorax. Remember, this is going from below upwards towards the heart. So sometimes, you know, when you get questions, read the question carefully. You might get a choice where one part of the choice is correct, but the second part may be wrong. So, you know, if you're looking at it and you think, oh, everything is correct, read it carefully, because, you know, it might just say that the lymph in thoracic duct or the thoracic duct goes from thorax into abdomen instead of saying from abdomen into thorax. Okay. Let's look at lymph nodules or lymph follicles, and these are discrete lymph nodules or discrete lymph follicles which are present as part of other organs, and these are seen anywhere in the bronchus, in the respiratory tract, gastrointestinal tract. In the small intestine, they are known as Peyer's patches. When they are present in the small intestine, they are given a special name. They are called Peyer's patches. Elsewhere in the gastrointestinal tract, you see them, but they don't get a special name. You can see it in the genitourinary tract, anything that's exposed to the outside. You want lymph follicles to be there, lymphatic tissue, so that it can kind of help take care of any infection. And this, you can see, this is a huge lymph nodule, and look at this lighter stained area here. This is a germinal center, so obviously infection was present. So you can see this area here. And this is what it would look like if you took a piece of the intestine where you can see these little follicles like this. Now, where would you not find lymph nodules or these lymph follicles? Epidermis, yes. You do see the gastrointestinal tract. The Peyer's patch is part of the gastrointestinal tract. I did say that anything exposed to the outside, and epidermis is exposed to the outside. But remember, in the first, when we started lymphatic tissue, I told you that anything which has a blood supply has lymphatic drainage, the exceptions being bone marrow and the brain. Epidermis, epithelium is avascular. There is no blood supply. So epidermis, you don't see lymphatic follicles. You might see it in the dermis, but not in the epidermis. Okay, so epidermis is the answer here. Then the next lymphatic organ is the spleen, the largest of the lymph organs. This is present in the left hypochondrium of the 9 abdominal regions. If you remember the 9 abdominal regions from ANP1, so we had these 9 regions. Do you remember them? So this one was right hypochondrium. This was called epigastrium. Left hypochondrium. This was called umbilical. This was hypogastrium. These two were lumbar. This was right iliac and this was left iliac. So the spleen is present here in the left hypochondriac area. Very, very large. It's related to the 9th, 10th and 11th ribs on the left side. Completely covered by peritoneum. Extremely vascular organ. It's related to a lot of abdominal structures, which you can see here. So here's the spleen. So notice all the structures it is related to. It is related here, it is related to the stomach. So that's why you have this gastric area. So the stomach lies on top of the spleen. It is related to the left kidney. So notice the left kidney and the left suprarenal. So that's why this is called the renal area. The colon, the large intestine also passes up. You know, it goes down like this and comes this way. So the large intestine also is related here. It's often where it turns and becomes the descending colon. This is often called the splenic flexure, just to tell you that it's related to the spleen. So that's why you have the colic area, as you can see here in this part. The pancreas, the tail, this part is called the tail of the pancreas. That is very closely related here. This is the area where the tail of the pancreas, this is the tail of the pancreas, very closely related to the spleen. And the spleen is really a very vascular structure. So you have to know all these, because if the spleen is injured, you know, when it enlarges, normally you cannot feel the spleen. It has to enlarge to 2 times its size. It has to double its size, twice its size, in order for you to actually be able to feel it under the costal margin. And, you know, any slight sort of hard hit or something can rupture an enlarged spleen. It's very, very soft, so you can't stitch it up, so you have to remove the spleen. So you then have to be careful that you know all these organs which are close by, and you don't want to catch hold of this tail of the pancreas when you're removing the spleen, because the tail of the pancreas has a lot of the endocrine portion of the pancreas. So if you remove that, you can make the patient diabetic. Apart from the fact that you open up the pancreas and all the digestive enzymes will begin to pour out. Okay? One of the functions of the spleen is it's called the graveyard of red blood cells. So it filters the blood, takes care of all the dying or dead red blood cells, and it kind of recirculates the pigments and the iron and all back into circulation. In the fetus, it was an area where blood cells were manufactured, but not after birth. The bone marrow takes care of that. And here, so once you've paid attention to this, so imagine if you, so here are some of the features. Lies in the right hypochondrium, related to 7th to 9th rib, completely covered by peritoneum, must enlarge twice to be in order to palpate or feel it. Its function is to take care of the dying red blood cells. And here is the histology of the spleen. So the spleen does not have any cortex or medulla. So there's no cortex or medulla. It does have a capsule. So if we draw the spleen, there is a capsule. And what the capsule does, the capsule, again, wherever you have a capsule, it sends in these little septae inside, or these are known as septae or trabeculae, again, same thing. Not well seen here is a small trabeculum that you see, but usually inside you'll see it's as very large, you know, you can actually see them as large pink structures like this, because they're cut in all different directions. So that's what a trabeculum will look like inside. And blood vessels will be seen inside it, because blood vessels go into the trabeculae in order to reach inside. And in the spleen, what you see is that one is it gives a very red and blue appearance. And you see areas where it's blue and collected as lymph follicles. And other areas it's kind of just, you know, it's got red and blue over here. The areas where you find where it's blue and collected in the form of follicles, you call it white pulp. You just don't call it follicles, you call it white pulp. And this is made up of lymphocytes and macrophages. So the cells, the lymphocytes and macrophages aggregate together, forming a nodule or a follicle, and we just call it white pulp. In the other area here, which is the red pulp, in the red pulp you find those red blood cells, the ones which are come to die, and there's also a lot of blood flowing there. And you'll find lymphocytes, monocytes, macrophages, all of these will also be present, but they are all present loosely. They are not kind of aggregated together in the form of a follicle. Okay, so that is very typical of spleen, having a red pulp and white pulp. Okay, no cortex or medulla. So no cortex or medulla, scattered follicles which we call white pulp, and then there are free RBCs, macrophages, lymphocytes, which is the area which we call red pulp. Now, because of the fact that the spleen is such a soft organ, very close to the ribs, it can be injured quite frequently. So here, if we are looking at a side view, so here's the spleen. I remember it was covered by peritoneum. So here's the peritoneal cavity. The spleen is related to the 9th, 10th and 11th ribs. So it's also related because it's on the left side, it's also related to the left pleural cavity. This is the left pleural cavity. So imagine if someone had a stab wound going through that, you can understand that it can open up the pleural cavity, injure the diaphragm, because this part here, it's lying below the diaphragm. This here is the diaphragm. And then it enters the peritoneal cavity and then slashes the spleen. It could also injure a lot of organs close by which are present, okay, based on where the injury is. But you can see the pleural cavity could also be injured. So not only do you have an abdominal problem, you now have breathing problems also in addition to that. So in a splenic injury, based on that picture which you saw, which is of the following is least likely to be injured? So that's why looking at these PowerPoint slides is really important. Yes, it's the duodenum. The pleural cavity is likely to be injured. I just showed you in the previous slide here. Look at this, the pleural cavity. So this is the left side, so left pleural cavity. But if you look up here at these organs that the spleen, this is the duodenum. See, notice this? So far away from the spleen. So you had a choice of pleural cavity, yes. Left kidney, pancreas, all these are close by. The duodenum is so far away. This is on the right side. So this is least likely to be injured, okay? So that's why the duodenum was the answer to this question. So let's look now, just do a bit of review. Which of the following would be typical of thymic histology? And here read the question, and I'm saying typical of thymic histology. Okay, the correct answer is number 2. And here's why. The thymus does have cortex and medulla. But remember, the lymph node also has cortex and medulla. So it's not typical of the thymus because the lymph node also has cortex and medulla. The presence of those pink onion skin-like structures, remember I told you, Hassel's corpuscles, that is typical of the thymus because that's only present in the thymus. You see that? Epithelium, of course, is only in the tonsils. And red pulp is present in the spleen. So therefore, the presence of it, when you say typical, that means only the thymus has it. Nothing else has it. Cortex and medulla, well, the lymph node has. So you can't use that. Okay. So presence of Hassel's corpuscles, which are pink onion skin-like structures. So let's say you're looking at a slide of a lymph node. How would you be able to tell if there is an infection? Yes, very good. And I said slide, so you can't see pus in the slides and you can't, and not necessarily by bacteria. So you can see the pale staining germinal centers. Yes, okay.